My presentation is about the role of modulators in CFRD. And so I will go first over the available CFTR modulators and then discuss how CFTR correction could affect diabetes, and then discuss the existing studies on that, and then end with future directions. So CF modulators are considered the most significant advancement in treatment of CF, and to date we have 4 available modulator therapies, and the modulators we have fall into 2 categories. So we have the correctors that correct or improve the processing and delivery of the CFTR protein to the cell surface, and then we have the potentiators that potentiate or increase the function of CFTR on the cell surface. And the first modulator therapy to be approved was ivacaftor in 2012, and it's approved for about 5% of CF patients, mainly gating mutations. And then, and we, as you know, have seen significant improvement in lung function and BMI and exacerbations with ivacaftor. And then next, we have our Cambi in 2015, and then Symdeko in 2018, and both are a combination of a modulator, of a corrector and a potentiator. And the improvement that were seen with these modulator therapies were modest compared to what was seen with ivacaftor. And then in 2019, the first triple modulator therapy was approved, Trikafta, and 95% of CF patients are eligible. And as you know, we've seen significant improvement in lung function, respiratory quality of life, exacerbation rates, and BMI. And so together, ivacaftor and Trikafta are considered highly effective modulator therapies. So we do know a lot about how CFTR correction affect the lungs, but we don't know much about diabetes. So there are many possibilities and options. If CFTR is expressed in the beta cells, then correcting it will lead to improved insulin secretion. If it's expressed in the alpha cells, then correcting CFTR will lead to improved alpha cell function and release inhibition of the beta cells. I'll just do that. And then if CFTR function in the ductal cells is directly important to the islet, then correcting the dysfunction will lead to improved islet function by paracrine action. And if inflammation has a role or affects islet function, then by improving inflammation indirectly, that will lead to improving islet function. And lastly, if exocrine destruction destabilizes the islet, then if we are able to correct CFTR early on and prevent the exocrine destruction, we might be able to prevent CFRD. So this study done by some colleagues from University of Iowa, they administered ivacaftor in utero and postnatally for a few months in ferret models of CF. And they found that the majority of treated homozygous ferrets with gating mutation maintained pancreatic sufficiency in the first few months after birth, and they also had normal glucose tolerance compared to those who were heterozygous or knockout ferrets. They developed pancreatic insufficiency and abnormal glucose tolerance. And more interestingly, when they withdrew ivacaftor, so this graph here, this is fecal elastase over time. They withdrew it gradually, and the animals who were pancreatic sufficient, within 3 weeks, all of them became pancreatic insufficient after withdrawing ivacaftor. And then when they did mixed meal tolerance testing, the first graph here is on ivacaftor. All these homozygous animals had normal glucose tolerance. And then a month after stopping ivacaftor, one animal developed diabetes. And then 3 to 5 months later, the animal who had diabetes had normal glucose tolerance, but another animal developed diabetes. So this indicates that CFTR dysfunction plays a role in diabetes development. So in terms of the existing studies on modulators and diabetes, so starting with ivacaftor for gating mutations, I was able to find 5 studies in the literature that looked at this question. And as you can see, most of these studies are a small number of patients, except the Volkova study, which is a registry study. It was a wide age range, different glucose tolerance categories, and most of the studies did OGTTs before and after. Some just looked at A1C, some did more detailed studies. But overall, the outcome were improvement, whether it's in glucose tolerance, insulin secretion, A1C, and glycemic control. So I will expand on some of these studies. So this one by Andy Kelly in 2019, they looked at 12 patients, median age 13 and a half years, mostly normal glucose tolerance, but they had some patient with abnormal glucose tolerance, and they did OGTTs, mixed meal testing, and glucose potentiated arginine test before and 4 months after ivacaftor. And so with OGTTs and mixed meal tolerance testing, they found no changes from before to after, except for an increase in early phase C peptides. But when they did the glucose potentiated arginine test, so they found that the first phase and the glucose potentiation of arginine-induced C-peptide response improved from before to after ivacaftor treatment. And I want to point that this is a young group of patients with very mild glycemic abnormalities, so it is not unexpected that there was no significant difference in the OGTTs and mixed meal testing, but the finding of increased insulin secretion is still significant and probably have more implications if these patients are followed for a longer period of time. The second study I want to just discuss a little bit is the registry study. So they looked at US CF registry and UK CF registry, and they looked at patients who were treated with ivacaftor and comparator cohorts that were matched by age, gender, and disease severity. And they compared the prevalence of CFRD in these two cohorts over the course of 5 years. So this is here on the left, the US cohort. The gray is ivacaftor treated, and the black is the comparator cohort. And this is the UK data here. And over time, the prevalence of CFRD was lower, or the increase in prevalence of CFRD was lower in the ivacaftor treated compared to the comparator cohort in both the US and the UK cohort. And again, this is also confounded by screening rates and by the fact that these cohorts were not matched by the same genotype. The comparator cohort did have a lot of delta F508, which they have a baseline higher rate of CFRD. Moving to the Orkambi studies for F508 deletion homozygous. So there are, or I found 5 studies in the literature, slightly larger number of the ivacaftor studies, and they also mainly did OGTTs before and after. And overall, in the studies, there was either worsening of glucose tolerance or no change, except for one study, which is the French study, that found improvement. They looked at 40 patients, mean age 24 years. All their patients were either IGT or CFRD, so they didn't have any NGT patients. And they did an OGTT a year after starting treatment and compared it to before. And so they found that out of the this is 31 IGT. They had 18 NGT, and out of the 9 CFRD, 2 became NGT and 3 had impaired glucose tolerance at follow-up. So about half of their patients had improved in their glucose tolerance, and then when they looked at the 2-hour glucose, they found that it decreased from to 139 after treatment from 171 before treatment. So they concluded that there is improvement with Orkambi in glucose tolerance. The other study is by Amir Mohit in 2020, where he looked at 39 patients, mean age 22 years. So they included patients with NGT and different glucose tolerance categories and CFRD. And it was more detailed, so he did OGTTs before 3, 6, and 12 months on therapy. And they basically found that glucose tolerance category was the same in 50% of the patients, improved in 1/4 of the patient, and worsened in 1/4 of the patients. And then when they looked at fasting glucose, 2-hour and area under the curve glucose, they found no difference from before to 3, 6, and 12 months of therapy. And similarly with insulin secretion and time to peak insulin, there was no difference from before to after treatment. And this was not very unexpected because Orkambi has limited effect on CFTR activity, so that could explain why. The last study I want to mention came out recently in June 2021 by Gaines and colleagues, and they did a retrospective chart review and looked at mainly CFRD patients on modulators and compared them to CFRD not on modulators. So they had 2 on ivacaftor, 8 on Orkambi, 4 on Symdeko. So this is the only study that included Symdeko. And they reported that CFRD resolved in 5 out of these 14 patients on modulators, on average 8.4 months after starting treatment. So this table here includes the patient who had resolution of CFRD. So what's interesting is some of these patients had CFRD for like 8 or 9 years before starting treatment, and 2 were on ivacaftor and 3 were on Orkambi. And 3 out of these 5 patients continued to have hypoglycemia even after stopping insulin. So it's interesting that these patients had long-standing CFRD, and it's also interesting that it took some time for CFRD to resolve, which means that the effects might take some time to realize. So in terms of future directions, there's no studies yet on the effect of Trikafta on CFRD, but the PROMISE study is an ongoing study that is looking at clinical effects of significantly corrected CFTR, and there is an endocrine sub-study where they're doing OGTTs before treatment, and then 12 and 24 months after, they're looking at insulin secretory measures, incretins, and different measures. So we're all looking forward to hearing about the results of this study. So I think there's still a lot of things to learn or know about how Trikafta will work. This slide is my own speculation on how Trikafta might affect CFRD. So I already discussed how CFRD correction can have a positive effect on the islet, and that will lead to improved insulin secretion. Also wonder if with the improved quality of life and increased physical activity, are they going to become more insulin sensitive? But on the other side, we're seeing increased hunger, increased appetite, they're consuming more calories, they have better GI function and absorption, so that will lead or might lead to excessive weight gain and obesity, and in turn cause increased insulin resistance. We also have to think about the effect of Trikafta on different age group in prepubertal children before onset of diabetes versus pubertal when they have this physiologic insulin increase in insulin resistance, and in adults where CFRD is already established. So including this from the CF community blog, a patient with CF describing her experience with Trikafta. I think it resonates a lot with my own clinical experience with Trikafta. So she says that CFRD is the cloud in my Trikafta silver lining. So she goes on to describe all the health gains and benefits she had with Trikafta in terms of her lungs and coming off all these medication and breathing treatments. But then when it comes to CFRD, she says that the control of her CFRD has been elusive, that the blood sugars are very unpredictable, they have a mind of their own, and they did not level out a few months after starting treatment despite her best efforts. And then she says that she thinks CFRD is the hardest part of having CF. So I think there's still a lot of questions that are not answered, and kind of in terms of future direction, one of the main questions is whether the defect in insulin secretion in CF is reversible or at least partially correctable. And hopefully in animal studies, we will be able to answer these questions. And then the next question, does Trikafta improve glucose tolerance and diabetes in CF or no? What is the ideal age of starting Trikafta? Does starting it at a young age help prevent diabetes? And if so, when is that? Should we do it before birth or in the first few months after birth? And then finally, we're seeing a lot of weight gain and obesity with Trikafta, so how will that affect diabetes development? And also, if we are able to protect the beta cells by starting Trikafta early on, with the obesity, are we going to be able to sustain that effect long term? That's all what I have.